I'm the speaker, in spite of the appearances. And I would like to thank Eric for letting me come and present to you some of my interests and my work. So I'm trained as a psychiatrist, and I came to cultural psychiatry from working with psychosis in a way, on a different path from most of the people, I think. And that's what I'm going to try to talk about today, about how you could do research and clinical work with people with psychosis while using also culture in this. And it's going to be a quite unstructured presentation. I'm going to present you a couple of different things. My goal is more to create an interest in you in the field than in giving you a take-home message. Oh, did I tell you half of my time I'm a psychiatrist in a first episode psychosis clinic, and half of the time I'm doing research on cultural issues. These days it's about stigma in psychosis. So first, culture. As I said, I'm coming to studying culture from a different perspective than somebody who would go from anthropology to psychiatry. I went the other way. And I'm much more interested in this kind of new forms of culture, or forms of culture which are much closer to us than studying some small Indian village or whatever, some Aboriginal people in the Amazons, or the classical things that you might read in books. And I found a picture like that, about the cyber culture, which I think it's one of the most fascinating domains to study today. How we make sense of what kind of new forms of subjective experiences you have when you're in a cyberspace, what kind of new social interactions do you have in that space. To go and to begin to talk about psychosis, I thought that I should begin with the definition of psychosis.Maybe not all of you heard about what psychosis is. So I went to the Webster, Merriam-Webster, and it says that it's a fundamental derangement of the mind, as in schizophrenia, characterized by defective or lost contact with reality, especially as evidenced by delusions, hallucinations, disorganized speech and behavior. So it's a question of defective or lost contact with reality. And one of the most fascinating things is, of course, to study what is reality, and then to try to understand what does it mean to have a break or a loss of contact with reality. And this is something that interests me, and hopefully it will interest you. I'm going to talk a bit about that. Most people who are studying psychosis are not interested in culture or social, social aspects, yes, but cultural aspects much less, or subjectivity in psychosis. Mostly because the official narrative about psychosis or schizophrenia is something that looks like that. It says that, schizophrenia or psychosis, I'm using both words to talk about essentially the same thing. Schizophrenia is a neurodevelopmental condition with a strong genetic basis, which is biologically based. It develops through time, it has stages, and it should be treated essentially with medication, to the point that it's probably the only psychiatric condition where they dare say that psychoanalysis is not only useless, but counterindicated. So you shouldn't do psychoanalysis with your patients. So when you have this narrative, this understanding of psychosis, what would be the interest of an anthropologist or a social scientist to work on it? There's not that much, And, the usual interest of somebody who embraces completely a neurobiological model of psychosis would be, for example, to look at the way culture influences the expression of symptoms, or to look at how culture influences the reliability of a diagnosis, which are, quite superficial ways of working with culture and not very interesting in general. It might be something that will give you some bread and butter because you can get a grant with that, but otherwise it's not, groundbreaking research. I think that so my goal is to explode this narrative and to show you other possible narratives and other ways of seeing things. And I will begin with, I think my computer is actually, there's a, how do you call that? A lapse? A Freudian slip. It's a Freudian slip, so my computer has a Freudian slip. Maybe, it's going to work. Here. So the interest of the practice in psychiatry is concerning these kind of delusional ideas. He's talking about the President Schreber case. Is usually limited to recording the effects of delusions and to evaluating their influence on the general behavior of the sick person. The astonishment of the physician in the presence of this phenomena is not the beginning of their comprehension. And then he goes on, he tries to sell psychoanalysis about that. I say, the psychoanalyst, on the contrary, in light of this knowledge, approaches this phenomena with a hypothesis that psychic manifestation, however singular and far from usual thoughts, are stemming from the most general and natural processes of the psychic life. So it's certainly a quite different view on, what could be psychosis. It's not necessarily a biological process, but something that happens in the psychic dimension of life, of the human being, and which is moved by more or less the same mechanism as we all are in one way or another. And it really certainly spoke to me a lot when I began involved into this field, especially that I was sharing a lot of this astonishment that he is telling. And I think anybody who works with people with psychosis would experience something like that, either astonishment or fascination or, or radical alterity in face of that. And the question is what you do after that. Freud went one way. More contemporary people are going other ways. And so he was trying to make sense of this kind of radical subjective experience that you can observe in other persons when they talk about their delusions and hallucinations by using a psychodynamic model with defense mechanism or whatever the first or the second topic. Another way of trying to make sense of what's happening is by seeing a bit the limitations of how much we can get into what the other person experiences. And this is my supervisor who was saying that. He says, we of course do not have direct access to the experience of others. We can inquire directly and explicitly, but we often learn most about experience through stories people tell about things that have happened to them and around them. So when the subjective experience which needs to be transmitted to the other one, from the patient to the clinician or to the researcher, is something that could be shared easily, let's say anxiety or depression, then there's something, there are some words, some concepts and symbols which are easily available in the culture, which help into this translation. However, this kind of difficulty to get to the experience is much more present when the experience is radically different or quite strange and quite unacceptable for the other one. That's another way of understanding it. And this is where, and I'm trying to sell my own salad here, this is where it's interesting to try to pay attention to the mechanism of transmitting those things. And it gets into narratology, if you want to, or the study of illness narratives. So the idea is that instead of simply asking somebody a question and recording that answer and analyzing that answer as being the truth, you pay attention to other dimensions. So you take a narrative stance in the sense that you pay attention to who is speaking and what is the audience and what kind of story is told. You have a plot in a story and there are different plots. You have dramas, tragedies, etc. And you can have also different points of view. For example, some people could have external points of view, others are much more subjective points of view. So a very simple example of that, if somebody asks you, tell me the story of your life, okay? As a narrator, you will tell a radically different story if that question is answered in a job interview, or whether it's answered by, it's questioned by, by a friend in a coffee shop, or by a therapist on a couch. So it depends a lot on the audience and what is the intended effect of your narrative. And it's not that one narrative is truer than the other one, it's just that they serve different purposes, and it's just normal that they would be different. I don't know if you saw also The Life of Others, that the German movie. Okay, one way of detecting, I like that a lot, that image, because one way of detecting a lie is by asking the person to repeat the story all over again. And if the story is not changing, it's because it's not a true story. I don't know if you remember that phase with the interrogator. Okay? So a true narrative is something which is fluid, which is a process which happens not in an empty space, but happens in an interaction between people, and which is also circumscribed by structural forms which are already pre-established. So you cannot have, not all experiences could be expressed easily through narratives. And some part of the experience is cut when you have to translate it as a story. Then the interesting thing of narratology, not besides the fact that you can use all the literary critical theory to build on it, you can import that knowledge into your field. Then the interesting thing is also that you can measure a couple of dimensions of an illness narrative in different ways. You might hear about the Minnie McGill illness narrative interview, or in the next courses you will hear about that, which is an interview that collects illness narratives, and then they could be you could study the content of the narratives, and to study different parts of what a narrative is. Part of it would be causal explanations in a narrative. The other part of the content would be prototypes. So usually when you talk about causal explanations, everybody understands that. It's when I am asking you, well, tell me about your diabetes. You say, well, I think my diabetes is due to being overweight and having a family history of that. Causal, risk, understanding. But then there's another form of knowledge which appears in a narrative, which is more about images. So somebody would say, well, my grandmother had diabetes, and that makes me anxious because I don't want to have my foot amputated. Okay? So there's an image that appears, which also contains a lot of knowledge, has a lot of implication for the behavior and the affect, which is there in the narrative, but it's not a rational form, or a less rational form. And then you have also some form of loose association, chain complexes are called, which are even more remote from rational thinking. Something like, somebody disliking a pillbox. Many of my patients dislike pillbox, and when you try to understand why, the only thing they could find is that, oh yeah, my grandmother had a pillbox. So the link is very tenuous, but it has emotional and behavioral implications. Then you can also study the coherence, the logic, and the quantity of details in a narrative. So for example, if you use another tool which is called the Indiana Psychiatric Illness Narrative, IPII, you have a narrative coherence rating scale that you can apply on the narratives that you're collecting, and stand is scale to assess narrative development. So, for example, if you do a therapy, you can assess at different points how much that narrative is changing and in which ways. And then you can also study narratives not only on an individual or interpersonal level, but you can also study meta-narratives. So what kind of stories are told about psychosis in newspapers, or the link between culture and subjectivity. I'm going to talk more about that at the end of the talk. Now, what I wanted to do actually is to give you, concrete examples of what kind of stories are told by patients, and especially by patients in clinical interviews. And so you heard the kind of global overarching narrative that I was trying to propose to you, and you might read that in most scientific papers about psychosis or schizophrenia. They will tell schizophrenia is a neurodevelopmental disorder that includes hallucinations, delusions, and essentially a break from reality. Now, when we did go and interview people who are who are in the early phases of their psychosis, in, let's say, the first year of having an episode of psychosis or seeking help for that. And we asked them about what was happening. So we tried to have a deeper understanding of what was really happening, what were the first signs, the first changes. We're trying to have a non-psychiatric way of asking questions. If you ask what are the symptoms, people will automatically tell you about the symptoms that they are told that those are symptoms. Okay? But what were the first changes? What were the first things that bothered you? It's a more neutral way of asking those things. And so that was in Boston. I was doing this study, and it was about 5 interviews over a period of 6 months, each of them for 1 to 2 hours. Because sometimes patients are very happy to tell you about their delusions and delusional content, but it's tough to hear that and to find a comfortable place to hear that story. But no, they were mostly treated, or at least they've been treated not a long time ago. Some of them were a bit symptomatic. I did not include them because it would be a bit more difficult to analyze. But so one of them was telling me that actually his main problem was related to political thinking. And he was saying that he began to refuse to go to college. He was from a rich family, going to a nice, expensive college in the Boston area, you could imagine. And he said, I felt it was too much money and I didn't want to. I was hesitant about spending so much money for an education because I felt it could be enslaving other people who don't have that chance. And then that thinking became even more about the system and social justice, but also control. And then all of a sudden I was worried about the outcome of playing into the system, sort of. And he would begin to have a more critical view of the political system. In many ways, he was probably very close to the Occupy movement, or to what you have now in Montreal. However, for various reasons, these kind of changes, which I'm calling here political engagement / engulfment, brought him into another sphere, which is the sphere of not only stopping to go to college, but also stopping using cars. And so he went back home to live with his parents, but the family was living in a suburban region where the car is absolutely necessary in the United States. So he would have to walk like 5 kilometers to get to 7-Eleven or to get anything. So it became much more difficult and much more of a problem, this kind of political engagement, than what is described there in the beginning, but it certainly began with a thinking which is quite close to the movements that you see today in the broader political arena. Another one was clearly talking about this social context. And he was saying, I have all this free time. I'm not going to school, I'm not partying, I'm just drinking by myself. I don't know, I just got bored, just watching TV, doing stupid things around the house, and then I rolled a joint and I smoked by myself, and I heard voices afterwards and started getting like paranoid and shit. It was bad. So when I heard more voices, then I heard more voices because of that. Now again, it's a very different view from, neurobiological developmental disorder. It talks about what is what is life today in a suburban region of United States, about boredom, about this kind of alienation that he's not using the term, but that's something that you can feel in that, he was just there alone, trying to play into the into the society of, what do you call that? The society of a hedonistic society, okay? And then, things are just falling apart. Some marijuana helps also. Another one was talking about how about a year ago I started feeling awkward and kind of a little off. And then I started having tactile hallucinations. I started thinking that bugs were crawling on me, especially at night. And then my mind started playing tricks on me. Stuff that happens inside my head, like I can't describe it. It's like trying to describe a song without singing the words to it. You're like, oh yes, that song, it's kind of poppy and it kind of goes like this, and people would never know what you're singing. And I kind of feel like the same way. And this is another part of, trying to work with subjective experiences of psychosis, is that sometimes we don't really have the words to talk about that. And oftentimes, the words are never perfectly there to talk about things, including, the most concrete things of the world. But some symbols are even more lacking in our culture than others. And so I think this kind of difficulties to express, the beginning of psychosis, for example, feeling awkward, feeling a little bit off, it really shows that there's some lack of support, of symbolic support, to be able to elaborate on them, and then to be able to exchange about them and to transform them into something that could be workable in a therapy or in a social context. Another participant, I would have maybe random thoughts, maybe here and there, but after I had the experience where I zoned out in the mirror, everything just kind of came on at me. And it's kind of stayed with me. My whole perception was, things, if I wasn't there to see it or experience it, things didn't exist. Like if I live here today and I'm not looking at you, I'm not hearing you, you're not real. You're only real when I'm there to experience you. This is a classical description of solipsism. And the guy was not a philosopher. So when I told him, well, that sounds like solipsism, he was not, oh, what's that? Okay. So it's more coming from his own subjective experience than coming from outside. But he was trying to express how his relationship with the exterior world changed in a significant manner and was much more fragile than before. The sleep of reason produces monsters. Have you seen that painting by Goya? No? So I put it here because for two reasons. Because I think it talks about what my participant was saying, but also because in the American Journal of Psychiatry they put it every week. There's one, or every month there's one painting that they put, and they put it there and translate it differently. They said it's actually when reason sleeps, monsters arise. or something like that, which is a very different signification, you know, in the sense that you need to have the reason alive in order to protect yourself from monsters, while if you translate it like I did here, it means more that the reason itself, when dreaming, is producing monsters, which, you know, has different implications. The dreams of reason would be producing monsters, you know. Anyway, so my subject was saying that really complex brain working started to happen, you know, where, you know, you don't really have to have ideas, do you? And the more I tried to challenge myself, the more my brain would come up with a more complicated answer to make me wrong, like, can you read? And I'd be like, of course I can read. And are you sure? Maybe you can't read. And then suddenly my brain was getting bored. I think that was what was happening, and it was looking for ways to torture me. He's talking about his brain torturing him. So what he's describing in this thing and in the rest of the interviews is that he began to be very reflective about things. In a way, he became very hyper-reflective about his life and about his experiences and his own body. So this kind of a Cartesian dualism that goes wrong and becomes hyper-reflective. So what I was trying to do with these kind of images, you know, is just to show you what kind of variety of experiences, a variety of narratives you could have when you study psychosis. So it could be much more interesting than asking only questions about symptoms, only questions about treatment, or in a way even recovery, for example, which is always goal-oriented and very pragmatic. You can get into some questions or some relationship between the culture and the experience of the person, which are much more complex and interesting. What I'll try to do now is to be a bit more concrete. Do you guys have any questions or reactions? Okay. So I'm going to be a bit more concrete and to talk about facts, if you want to. And I'm going to talk also about some facts which are questioning the narrative, the official narrative. The official, besides the individuals who are questioning the narrative in the first part. So the official narrative is also a narrative of progress. You know, it's a narrative where we say that psychiatry evolved and is much better today than it was before, that our treatments are much more effective, much safer, okay, and that people are doing much better, and that as many people as they need should be treated in psychiatry, in the mainstream psychiatry, usually with medication, you know. Now, the problem with that narrative is, first of the problems with that narrative is that for psychosis, you have a lot of alternative treatment settings. So the first way of challenging that narrative is by observing that in psychosis, there are a lot of alternative treatment centers which are saying or claiming with different levels of evidence that they are much better than the usual care or the mainstream care that people get. And most of these alternative treatment settings are either refusing all medication or antipsychotic medication in the treatment plan, or using it very sparingly. So I'm giving you here two examples. One of them is something that is still alive today, is Trois-Huit in Quebec City. It's a psychoanalytic center for treating patients with psychosis. And they are not against medication, but they use it very rarely. So when they use about 15% of the average dosage that it's used in general care. But it's not a research center, so it's much more of a clinically oriented and psychoanalytically oriented place. So when they one of the main critics of ways of criticizing that is by saying that they actually have a special population which is much better than the rest of them. Now, Soteria was a project that took place in the 70s and 80s under the guidance of Lauren Mosher, and this was a research-based clinical intervention done by somebody who was in the beginning in the mainstream of psychiatric research. So he was the head of NIMH at a certain point. And then he drifted away, and finally he got ejected, or he ejected himself from the establishment, and he was considered to be, in the anti-psychiatry movement. But he was certainly very interested in research, so when he did his study, he did it in a randomized fashion, So patient would be randomized either to a local hospital or to come to his clinic. And he was very much against medication, to the point of having the patients not take the medication for the first 6 weeks. So they would have to wait 6 weeks before being allowed any kind of medication. And the results are quite interesting. I mean, the sample is not huge, it's about 150 patients per group, but they seem to be doing much better in the long term than patients who are treated in the general psychiatric settings. Another way of untangling this narrative of progress of the mainstream psychiatric care is by looking at historical trends. So if you would have real progress in the treatment efficacy, what you would like to see as improvement, okay, or outcome, or good outcome, would be something like that, which goes up here, no? Or at least plateaus at a certain point. Now, how do you explain the fact that since the 70s, the patients with schizophrenia are not improving, and it's getting worse? It's certainly going against this idea that there's a big progress, especially that in the late 80s, early 90s, we got the second generation of antipsychotics, which are supposed to be much more efficient than the first generation. And in this meta-analysis, what they did is that they looked at what were the predictors of the outcome. And interestingly enough, it's not the treatment modality. So it's not whether you were treated with psychotherapy or with medication or the kind of medication. I think only lobotomy was something that had a negative predictive value. But otherwise, what was defining the outcome were the inclusion and exclusion criteria. So the broader your understanding of schizophrenia, the more people who are less sick you include in your studies, the better the outcome. Which goes pretty much against, this vision of progress. It means that the only thing that matters is how you define the illness. So the more people who have good prognosis you have inside, the better that prognosis is. And finally, this is probably the study that delayed the global mental health movement for about 20 years. You guys heard about global mental health? And I think you'll have courses on that, and it's the next big thing. In the 70s, they tried to do cross-national comparisons of the outcome of schizophrenia in different countries, mostly with the idea that in developing countries, the outcome of schizophrenia would be worse than in developed countries. And then with that argument, they would fight for for having access to psychiatric care and medication for people in the developing countries. Well, against their expectation, I don't know how official were they in these expectations, but against that idea, what they found is that actually the outcome was much better in developing countries. And so you see on different ways of looking at outcome, the Bleuler recovery scale, GAF, Global Assessment of Functioning, Disability Assessment Scale, which measures disability, or the percentage of people who did not have psychotic symptoms in the last 2 years, or who were working, you have about 2 to 4 times more chances to have a positive outcome in a developing country than in a developed country. And this was quite embarrassing for psychiatry in a way, because most of those people in the developing countries did not have continuous psychiatric care, did not have continuous medication. They might have been treated for 1 or 2 episodes of psychosis, but most of the time they would, just live with their families. They would not have, supported housing or social services for that matter. And what they tried to do after that for the rest of the time is to replicate these studies, and they actually managed to replicate. This is a replication, actually, a follow-up with at least 10 years of follow-up for patients. The initial study was only 2 years. And they also tried to find reasons for that. So do you have any idea what would explain the better outcome? Here. Yeah, it makes sense. This kind of industrialized, atomized societies where you have too much freedom, you feel alienated from the others in the same time, compared to a more collectivist place where the family is closer, you have a feeling of being embedded into something, of participating, maybe. Those are kind of hypotheses. More specific ones, one of the more specific ones was about expressed emotions. Maybe you heard about that. So this idea that the way you interact in a family, which is quite culturally based, has implications about how people would recover or not. So in a family which is very confronting and aggressive and very critical, so very negative and with high expressed emotions, people with psychosis would tend to have more symptoms, that would exacerbate the symptoms, and they would fare less well because they wouldn't be able to recover well functionally. And that a more, accepting, maternal way of dealing with things without criticizing, it's a better way. The corollary of that is that that could be changed, the family dynamics can be changed through therapy. So then they began to do a lot of therapy with families and patients with schizophrenia, trying to to lower the expressed emotions. And then they had a range of ideas about, collectivists and about the society and things like that. Another way of understanding that is about tolerance. So how much tolerance do you have for abnormality, or for deviant behaviors, or for being a bit less productive than the other one? That's one of my favorite ones, because I'm always puzzled. My patients are trying to recover and to find a job, and the worst jobs that you could have, like work in a McDonald's, they still want you to perform like you would be top shape. They pay you very badly. It's really the worst conditions you could imagine for working. And yet, you have to do that burger in 14 seconds, otherwise you're fired. While, somebody in India, you could imagine somebody, if you visited India, that if you sell chai on the street as a street vendor, you could be a bit more sedated or a bit less fast in your movements and still, make a living out of that. You wouldn't end up without a job. Okay, the other thing that cuts, this narrative of progress is the historical comparison with the old asylums. Okay, this is David Healy. Maybe you heard about him. He's the one who was one of the most prominent persons to talk against the antidepressants and the risk of suicide with antidepressants. So what he did a historical studies a study of a particular region of England in North Wales, if I'm not mistaken, where the population did not change. So nobody moved, and it's more or less the same persons who are living there and the same things that they do. And there was an asylum before, and now there's a hospital. So he compared how many people died while they were hospitalized long term. I don't remember how many years, but it was at least 4 or 5 years of hospitalization, usually in an asylum. Most of the people were staying there for most of their lives, to what's happening in today's world when people are hospitalized for 1 or 2 weeks. And he found that actually 125 years later, people kill themselves about 20 times more when they suffer from schizophrenia than they did before. And he also controlled for depression, okay? And in depression is not, there are 11 out of 700, which is relatively close to, it's about 2% of the people who kill themselves. In today's world is maybe around 5%, so it's only 2.5. But the huge difference in suicide was 20 times more, was in patients with schizophrenia or with psychotic disorders. About the explanations of these things. Okay, so David Healy's explanation is actually more biologically based. He's saying that the antipsychotics are creating a form of dependency with a huge dysphoric component, and when you stop them, and most people stop them when they get out of the hospital, they become very dysphoric, and then they tend to kill themselves more. So it's more of a iatrogenic effect. Most of the people, though, are considering that it's actually more about stigma. Okay, so there's something about that label, but even more, that explains this kind of negative outcomes that you can observe, even with the best care possible. It's certainly, there's certainly a statistical link between having insight into your condition, high IQ, and suicide, so, and depressive symptoms. So, well, now what is the causal relationship between those things, and is that relating to this kind of deeply discrediting narratives about your condition, which so stigmatized narrative that you incorporate, so you accept? That's one possibility, but it could be also the fact that maybe the old psychiatrists who were never telling the diagnosis were not that crazy. Okay? From a practical point of view. From an ethical point of view, then it's something different. So to go back to stigma, usually when you hear about stigma, the first thing that you think is about labels, so you shouldn't use the S word, schizophrenia. We don't use it neither. A first episode Psychosis clinic and not schizophrenia. But just the label in itself is not a big problem, The label, let's take feminism, just the fact of naming somebody a woman or a man is not a huge problem, and we do that all the time without wanting to take that out. No feminist, I hope, is thinking of going in a men's bathroom instead of a woman's bathroom just to fight the label, okay? Because that label is just, part of how society is organized, I don't think anarchists are burning the red lights just because they are against any rules. I think they tend to be against other kind of rules. So the label in itself is just part of normal life. We have labels for many things. The problem is when the label gets structured into something much broader, which is a stereotype. Okay, and when the stereotype is also embedded with negative connotations. Okay, so let's say patients with schizophrenia are hopeless, or they are lazy, or they are unpredictable, or they are dangerous. Okay, so you get a label, and you put more on it. You create some kind of image with negative connotations. And the next step of that, even that, it's not the end of the world. okay? In the sense that we do that a lot with even our best friends. If you look at a group dynamic, people usually tend to find some kind of stable position which could be seen as stereotyped in a group, you know. Somebody is always the leader, or most of the time the leader, the other one is following, the other one is the joker, things like that, especially with younger, with kids and adolescents. But then the next step is when you create a separation of us and them, which is usually unbreachable, you know. These kind of separations are happening in racial discrimination, for example, based on skin color. You know, so you would say, you know, they are very different from us, just look at their skin. You know, so that's easy to make. It's quite unlikely that a white guy would become black. The other way around, it happens a little bit, but not that often. And this us and them, you know, is that what allows you. Well, one way of understanding that is, for example, to say that patients with schizophrenia could never be psychiatrists. This is one of the myths which is told in med school and in psychiatry on psychiatric wards, you know, that if you're schizophrenic, you cannot be a psychiatrist. You know, so it creates this kind of separation. And you could not become psychotic. That's another way of, I'm not made that way, so I cannot be psychotic, and the other one cannot. The implication of that is that the other one cannot really be non-psychotic. You know, he's in that category and he will stay there. He will never be really normal. And this separation is accompanied by an emotional reaction. You know, all the first things were cognitive processes, but then you have also emotional reactions. And sometimes the emotional reactions are not completely negative. It could be pity, it could be sorrow, okay? But it's still an emotion which might be for the other person discrediting, you know? Several persons told me, you know, I have nothing to do with your pity. You know, that's not something that I'm looking for. Discrimination is the behavioral part of that, is the fact that there's actually a behavior and concrete consequences for that. And that discrimination takes many forms. You know, it could be avoidance, it could be so individual forms of discrimination, like avoiding somebody, not wanting to live with somebody. I'm always asking the residents when I'm teaching the residents, how many of you would feel okay to live as roommates with somebody who is actively psychotic, you know, talking to himself alone in the kitchen at night. You know, it's very difficult to not to have an emotional reaction related to that, and not to feel somehow uneasy in that situation. There are also forms of discrimination which are more structural, and they are much more difficult to see. And most of my, one of my recent studies, I was asking people about their experience of discrimination, and things that I would identify as discriminatory in their lives, they would not identify them because they are structural, you know, or because there are also psychological reasons. That many of them is because it's structural, you know. So somebody would lost his job because he was working in the security industry. And you know, he said that's just part of the rules. You know, if you have a mental disorder, you cannot work for the army. Okay. Well, that's structural discrimination. It might have a reason to be there, but it's still discrimination in a way. Okay. It's not based on the ability of the person to work or not. It's just based on a diagnosis, on a past diagnosis. And all these things are happening also in a context where there is a power differential, in the sense that people who suffer from psychosis tend to be in a less powerful situation, and that's why they experience the stigma. Why is that important? Is, for example, because many of these processes are happening also with people who are helping patients with psychosis. You know, it's called stigma by proxy, okay, or courtesy stigma. So in the sense, many of my friends, when they learn that I'm a psychiatrist, they tend to joke about that, saying, oh, you're mind reading, you're doing this, you're doing that, or you're a bit off yourself, you know. But I'm not in a powerless situation, you know. I have a good job, I'm relatively well educated, so I don't experience the discrimination and the negative consequences of that. So if there's one or two who don't like me because of that, one, I can answer back, and two, I have many other friends that I can choose from. When you're a poor person on welfare and you're looking for a house, and the few houses which are available, the owners don't want to rent them to you because you are coming out of the mental hospital, you know, you will feel that discrimination much more because you don't have that many options, and you also don't know what your rights are. You know, you don't know that you can sue them for that, and you don't know how to do that in such a way that you would be successful at the end to sue them. So I see the time passing by, I have to go a bit faster. So this is a study about stigma, and what I would like to emphasize here is the fact that stigma has different dimensions, and some of them are very psychologically oriented. So for example, the idea that it's not only the stigma that you experience, but also the stigma that you anticipate, which matters. It's quite interesting. So Thornycroft here tried to see how much stigma is experienced or anticipated by patients with schizophrenia in different countries. And what you see is that a significant percentage, a third of the patients would anticipate stigma but not experience it. Thank you. And anticipating stigma has negative consequences, maybe as much as experienced stigma. So one of the big problems is also related to that separation process, which happens cognitively. You know, that you cannot be on the other side, is that, yes, doctors don't tend to seek help for psychiatric reasons. Maybe because they are well aware of the negative consequences and they anticipate them, and they try to find other ways. So they self-medicate, or they go to anonymous things. Now, there is an interesting study measuring the level of stigma between 1996 and 2006 during the decade of the brain. You know, so they try to see whether all this talk about the neurobiological basis of mental illness had diminished the stigma, because that's one of the main arguments to understand mental illness as a biological condition, you know, to say that we're not going to blame them and it's going to be diminishing the stigma. And what you see is that actually most of the ways of measuring through vignettes, you know, and through the social distance measures of stigma, most of them are not different from the past. And the few ones, I think the only statistically significant is this one, is going in the wrong direction compared to what was hypothesized, in the sense that there's increased stigma today about schizophrenia compared to what it was 15 years ago. And this was done again measuring, this is a meta-analysis, measuring in the general population what is their understanding of mental illness. So you see here that actually inherited and genetic models of mental illness and brain disease, or biomedical models of mental illness, get more and more accepted by the general population in different countries, both for schizophrenia and for depression. Maybe the trend is less evident, but it's statistically significant for depression also. When you look at that from the stigma perspective, you have the inverse trend, you know. And what you have, though, is that there is less acceptance of somebody with schizophrenia as a coworker now than it was before, or as a neighbor. Interestingly enough, that's not the same dynamic with depression. So depression seems to be less influenced by this, or not negatively influenced by that, by a biogenetic understanding of mental illness. This, this goes to your comment about psychoeducation. Psychoeducation is mostly this, is mostly enculturating the patient with a biomedical, biogenetic model of what is mental illness. You tell them it's a brain disease, you shouldn't blame yourself, or you shouldn't blame your family member, okay? And we have medical treatments, you should take these medications because it's a question of neurotransmitters. Well, it does some things. What it does, other people study that, it increases the acceptance of medication and of seeking help by the population, So it certainly increases the market for pharmaceutical companies, but it's not decreasing the stigma. Okay. It promotes, in meta-analysis it doesn't appear, but in other studies it appears, so it's diminishing the blame, but in the same time, because it's something which is not actually in your control, it's something in your brain or in your neurotransmitters, it increases the unpredictability and the perceived dangerosity of somebody who has a psychotic disorder. And that's maybe why you have more and more discussions about, violent patients with psychosis and, coercion and things like that. So the last part is going to be, do you have any comments about that, about this part? No? I aim to stop in about 10 minutes so that we can talk a bit, or you can have a longer break before your movie, if that's okay with you. So I'm very much interested to understand what are the conceptual tools that you can use to explore these kind of processes, How can you make sense of things? How can you detach yourself in order to be able to study something like psychosis? And the first thing is to learn something that we call culture is something that we all have, and which has a very important influence on how we see the world. So here I'm contrasting, I think you saw that already. I'm always using the same images. I'm contrasting a drawing of a person from a classical Chinese medical book and a drawing from a classical anatomy book from the 17th century, if I'm not wrong, 16th or 17th century, Vesali. And both are, long tradition of medicine, with very intelligent people. And the question is, how come they could draw the same human being in such a different way? And which one is the right one? As somebody who's trained in the Western world, I certainly find that Vesali here is he's a much better drawer or painter than the other one. The other one is lacking detail, and just look at the arm and the shoulder here is just not anatomically right. But then the question is, how come they would draw it that way? I mean, are they blind not to see what a human being looks like? And the author who was doing this kind of comparison was talking about the expressivity of the body. So how the body is not only something that you can see passively, which has some kind of objective reality, but also something that expresses things. And what you see is actually what is expressed through the body or what you're looking for in a body. So he's explaining, for example, that since the ancient Greeks, the Western understanding, broad generalizations, but they help a little bit, the Western understanding of the human being is related to agency, and the organ of the agency is the muscle, you know. So the more, for ancient Greeks, having big muscles means that you have a lot of agency, you have a lot of will, okay? And that's why you have this kind of ancient Greek statues of heroes which have 3 times more muscles than anatomically adequate. And you have all these people today who are doing bodybuilding and who look like Hercules and who become governors of California. Because they have the, they have the agency, the will, they are powerful persons. Now for the traditional Chinese medicine, what matters the most is the equilibrium between 2 energies, and those energies are circulating in the body. So the body is much more a question of a vessel, who circulates energy, and in that sense, a healthy person is somebody who has a vessel kind of form of body, who's able to have a lot of energy inside them, and to have a harmonious and well-balanced way of circulating that energy. So hence this kind of round forms in the other drawing. So that's one of the first things that you can do when you study culture, to try to look at the underlying assumptions about human beings, about reality, and to see how those things are expressed and how they influence the way we see the world or the things that we're studying. For example, with schizophrenia, one of the biggest critiques of schizophrenia is that it's based on the idea that the self is unitary, So it's the name, even the name is the idea that you have splitted functions of the self. So the functions of the self get splitted, and that's why you have the disease which is called schizophrenia. Now that's a very specific understanding of what the self is, which an understanding that appeared in the in the modern period, 19th century, 20th century. So for a Buddhist, for example, who doesn't think that the self is anything but illusion, it might not make that much sense when you talk about schizophrenia, because it would talk about splitting of an illusion. The other thing which you could use to understand this phenomena is to look at the broader context. This is especially enlightening for somebody like me who's a clinician, and who tended to look at things from the seat of the psychiatrist, And it was quite difficult to decenter myself from that and to ask questions which are not from my seat, and that's where medical anthropology helped me a lot, to help me understand that there are different sectors, the popular sector, the folk sector, which is all the alternative medicine and all the lay ways of getting help, and the professional sector. And that my patient will sit with me in an office at less than 1% of his time, and he would be most of the time there and there. And then what's happening in those other places is probably much more significant and important than what happens in the small office of the psychiatrist. Another thing that helped me was to look at how knowledge is translated or not from the different forms of knowledge production, especially from the scientific production of knowledge to the popular sphere. And I just love Tanya Luhrmann. She does great ethnographic work, and she said that psychiatric knowledge seeps into popular culture like the dye from a red shirt in hot water. And that explains sometimes why you might have good intentions, like cleaning this shirt, like helping people with schizophrenia, and it ends up with a big mess with everything getting stained. another way of understanding what's happening is questioning broader trends. And Ethan Waters, have any of you read this book, Crazy Like Us? Yeah. It's a beautiful book that it's a nice way of putting together in an accessible format many bodies of research about how illnesses are exported actually by the United States to different parts of the world. So it's a lot about globalization, which is I think one of the most important things that are happening now from a cultural point of view. And it shows that, as we exported McDonald's and we exported TV and Hollywood in different places, we are also exporting mental illness in a way, And there are ways of being aware of that, ways of doing that, and ethical questions related to it. But we should be at least aware of what it means. So it's not simply a question of some backward people somewhere that we want to help by making them aware that depression exists, and then giving them a treatment for that. It's much more than that. It's exporting also a way of understanding life, a way of interacting, and a way of understanding what's the end result and what you should expect. You should expect to be happy all the time. You should expect not to suffer, for example. You should expect to be yourself. There's a beautiful book by Erlenberg, a French sociologist, talking about depression and saying that depression in our society is more being tired of being oneself. There is this kind of huge impetus for us to be always ourselves, to be authentic, to be productive, and sometimes people just get tired of that. And the only way of expressing that is by saying, I'm depressed. Erlenberg, E-R-H-L-E, wait, I can give you the title. I'm not sure it's translated in English, but La fatigue d'être soi, being tired of oneself, is the concept. And finally, another way of analyzing that is by doing historical comparative studies of the images of different, images of madness or schizophrenia. So Jonathan Metzl, he's a very active researcher in this field. He's using methods, which are similar to Foucault, but in a more, an archaeology of ideas and images, but in a more structured manner. And for example, here he's showing, an ad from, the best psychiatric journal, the Archive of Psychiatry. And that's not that long time ago, it's 74. I was born in 76. And still, if you look at that today, you say it can't be that the best journal in psychiatry would publish this kind of image and not feel ashamed about it. Okay? And they certainly feel ashamed today, and they say it's not really what we wanted to say, but probably 20 years from now, I will feel ashamed about what I'm doing as a clinician, And it's always like that. And this helps you put into perspective things and also try to untangle what's really happening. So what was happening there is that the image of what schizophrenia is changed from the let's say the first half of the 20th century to the second half. So he traced back images of schizophrenia in texts and in clinical notes, and the image in the beginning of the 20th century in United States was the image of young, middle-class, white males, who would be a bit too imaginative and too poets, and who would be engulfed into some form of fantasy, They would be mostly inoffensive, so there was no big talk about dangerosity, and people would feel sorry for them, and they would be put into asylums. That's certainly what was doing. Then what happened is that during the periods of social protest, with the Black movement, Black Panthers, social protests, all these things, the population of the asylums changed. So the population changed to young, Black, dangerous Americans, from lower class, no longer middle class, and not related to being too intelligent or too imaginative, but more being related to being a protester and wanting to change things and to kill somebody eventually. And then all of a sudden, the problem is something about assaultiveness, belligerentness, and cooperation. And the cooperation is solved through pills, and a bit later through injection. And it helps in a way, to understand what are the kind of trends that are happening also today, and how much of the social anxieties of today's world get translated into psychiatric talk. So you have all these discussions, for example, today about terrorists. Is a terrorist a mental patient? If yes, what kind of mental patients? Should we keep them in a hospital, or should we kill them or put them in a prison? I think you have two opposites here. One which is local. I don't know if you heard about Dr. Turcotte. So it's a famous case in Quebec, okay, of a cardiologist who killed, in a quite planned manner, he killed his 2 kids. Yeah. And then he managed to be considered not criminally responsible and to be sent into a prison hospital. And now he's trying to get out about, 1.5 years later? Okay. On the other side, you have Breivik, okay, who's, on the complete opposite of that, who killed many people, and he's trying to say that he's not mentally ill. He's trying to prove that he's not mentally ill, while Dr. Turcotte was trying to prove desperately that he was mentally ill. And the society was pretty much divided for Dr. Turcotte, and they seem to be also quite divided regarding the Breivik for other reasons. So there is an intense debate about that, and the outcome would certainly have influences for everybody, and especially for mental patients, for patients with psychosis, because the more we talk about danger and link that with psychosis, the more stigmatized they are going to be by the society. Okay.